Imagine for a moment that you're just sitting at your kitchen table. You want to reach out and pick up your favorite coffee mug.
Right, just a completely everyday action.
Exactly. It's a movement you've performed, I don't know, tens of thousands of times in your life without a single conscious thought. Your brain sends the signal, your arm extends, your fingers wrap around the handle, and, you take a sip.
Simple enough.
Right. But now imagine waking up one day, looking at that exact same mug, sending that exact same command from your brain, and nothing happens.
Oh, wow.
Your arm just stays pinned to your side. The muscle is still there, completely intact. But the neurological bridge connecting your intent to your physical movement has been, well, severely damaged or completely washed out. Suddenly, the simplest daily tasks, opening a door, holding a fork, pulling on a shirt, they've become these monumental, exhausting mountains to climb.
It is an incredibly profound physical and emotional roadblock. And when we look at the global landscape of neurological health, it's a reality for a staggering number of people. We're talking about roughly 30.7 million people worldwide who have survived a stroke.
I mean, 30.7 million, that's huge.
It is massive.
Yeah.
And while surviving a stroke is, a medical triumph in itself, the immediate aftermath presents this huge hurdle. One of the primary debilitating deficits these survivors face is a profound loss of the ability to generate normal, voluntary muscle force.
Right, because the machinery of the muscle is intact, but the electrical grid of the nervous system has been basically compromised.
Precisely, the power lines are down, essentially.
Which brings us to a really compelling question. If the muscle itself is fundamentally fine, but the signal from the brain is broken, what if we could just, bypass the brain entirely? What if we could hijack the muscle and force it to work from the outside in?
That is the exact premise of what we're looking at today.
Yeah, so we are diving deep today into a stack of materials that explore exactly that. We have a highly rigorous 2014 systematic review and meta-analysis from the Journal of Physiotherapy, put together by a team at the University of Sydney and a few other institutions. And alongside that, we're pulling insights from a really accessible clinical translation blog post that helps bridge the gap between, dense academic data and everyday application.
It provides a fantastic contrast, really. On one side, we have the highest standard of evidence-based medical research, a meta-analysis that aggregates multiple clinical trials to find the absolute truth hidden in all that data.
Right.
And on the other, we have a clear, practical interpretation of what those findings actually mean for a patient sitting in a physical therapy clinic.
Okay, let's unpack this. Our mission today is to figure out how a specific technology cyclical electrical muscle stimulation might be the key to rebuilding that lost strength and handing stroke survivors back their independence. But before we get into the heavy data, I need you to clarify something for me.
Sure, what's that?
Well, electrical stimulation sounds like a really broad umbrella. Like, I've seen people use those little electric patches for back pain, and I've seen them used in high-end sports training. What exactly are we talking about when we say cyclical electrical stimulation?
Yeah, that is a critical distinction to make right away because the clinical terminology can be very specific. The researchers in this review use a framework by De Kroon and colleagues that basically divides electrical stimulation for stroke patients into two major buckets.
Okay, two buckets.
Right. So the first bucket is what we call functional electrical stimulation.
Meaning the electricity is serving a direct functional purpose in that exact moment.
Exactly. In a functional setup, a physical therapist uses the electrical current to stimulate a muscle while the patient is actively trying to perform a complex task.
Oh, like trying to grab something.
Or walking, yeah.
Well,
Think about a stroke survivor trying to walk, but they suffer from drop foot. That means they can't lift their toes, so they trip. A functional device would zap the shin muscles at the exact millisecond they swing their leg forward, forcing the foot to lift.
I see. So the electricity is acting as a real-time mechanical assist to complete the movement.
Right. But that is entirely different from the second bucket, which is the sole focus of our deep dive today, cyclical electrical stimulation.
Okay, so take the activity out of the equation. What does the cyclical version look like?
Imagine a patient sitting comfortably in a chair. They aren't trying to walk or grasp a cup or anything. The physical therapist places electrode pads over a specific weakened muscle, let's say the bicep.
Okay.
The machine then delivers a series of gentle but building electrical pulses directly through the skin into the motor nerve. This artificially triggers a near maximum contraction of that bicep. The machine holds that intense contraction for a few seconds, then relaxes.
And it just keeps doing that?
Yeah, it repeats the cycle. Contract, relax, contract, relax. It operates completely independently of any complex task. The sole, singular goal is to repetitively stimulate the muscle, to force it to work hard and get stronger.
I love analogies, and this feels like having a car with a perfectly good engine, but the ignition switch on the dashboard is totally fried. You can turn the key all day, meaning the brain is trying to send the signal, but the car won't start.
That's a great way to put it.
Right. So cyclical electrical stimulation is basically opening the hood, taking jumper cables, and sparking the battery directly. You're giving the muscles a focused workout even when the brain is struggling to send the memo. You're forcing the engine to rev without ever touching the broken ignition switch.
That is a highly accurate way to visualize it. And what's fascinating here is the biology behind why this is so necessary.
Yeah.
Normally, if you or I want to build muscle strength, we have to engage in progressive resistance training.
You go to the gym, pick up a dumbbell.
Right. You actively, voluntarily force your muscle fibers to contract against gravity and weight. When you do that, you're increasing motor unit activity, which simply means your brain is recruiting more nerves and the muscle fibers they control to join the effort. Over time, the muscle adapts by increasing its cross-sectional area. It gets thicker, denser, and stronger.
But a stroke patient with profound weakness just can't do that. I mean, if you hand a 5-pound dumbbell to someone who just had a severe stroke, they physically cannot lift it. They might not even be able to lift the weight of their own forearm against gravity.
Exactly. So they are locked out of traditional strength training. Their muscles sit dormant, and because of the use it or lose it nature of human biology, those muscles quickly begin to atrophy and waste away.
Wow.
Cyclical electrical stimulation bypasses that bottleneck. It provides a back door into the muscle. The machine recruits the motor units. The machine provides the intense contraction. The muscle is forced to adapt, thicken, and maintain its viability, all without requiring a single voluntary neural command from the patient's damaged brain.
Okay, that paints a very clear picture of the mechanics. We're artificially giving the muscle a heavy workout. But, a great theory doesn't always translate to great medicine. We really need to look at the hard evidence. Let's dig into this University of Sydney meta-analysis. First off, I know meta-analyses are considered the gold standard in research. How big of a data pool are we looking at here?
It is a highly robust sample size for this specific field of neurological rehabilitation. The researchers didn't just run one experiment. They scoured the medical literature and pulled together 16 distinct clinical trials.
16 trials.
Yeah, and those trials involved a total of 638 stroke survivors.
See, when you combine that many different studies from different clinics, how do you know the data isn't garbage? You could have one clinic running a brilliant, tightly controlled study and another clinic where the data is just sloppy.
You run them all through a rigorous quality filter.
Yeah.
In this case, the researchers use something called the PEDRO scale. It stands for the Physiotherapy Evidence Database Scale. It's an 11-point checklist designed specifically to weed out poorly designed studies. It looks for critical things like random allocation, like did patients have an equal chance of getting the treatment or the placebo?
Right.
It asks if the researchers who measured the final outcomes were blinded so their own biases didn't skew the results. It essentially separates genuine clinical science from snake oil.
Okay, so they put these 16 trials through the Pedro ringer. How did they score?
The average score across the trials was a 5 out of 10. The researchers formally classify this as moderate quality.
Wait, I have to pause you there because to anyone listening, a 5 out of 10 sounds like an F on a report card. Why is the gold standard of research relying on studies that barely pass the halfway mark?
It sounds alarming, I know. But there is a very practical, unavoidable, logistical reason for that score, and it comes down to a crucial element of clinical trials, which is blinding.
Blinding, like a double-blind test.
Exactly. In a perfect drug trial, you give half the patients the real pill and half a sugar pill. Neither the patient nor the doctor knows who got what until the end. But think about what cyclical electrical stimulation actually entails.
Oh, right. You are strapping electrode pads to a person's arm and shooting enough electricity into them to cause a massive involuntary muscle spasm. You can't exactly fake that.
You really can't. If you're a patient in the placebo group and your machine isn't sending a strong current, your arm isn't moving, you know immediately you are not getting the real therapy. And the physical therapist standing next to you watching your arm lie flat also knows.
Right, right.
So nearly all of these trials lost points on the Pedro scale because patient and therapist blinding was physically impossible. However, the trials did successfully blind the independent assessors, the people who came in at the end of the study to measure the patient's strength. That protects the integrity of the actual data we are about to look at.
Okay, that makes a lot of sense. The 5 out of 10 isn't sloppy science. It's just the reality of testing a giant visible electrical zap. So the data is verified. What did they find? When they measured the pure, raw strength of these patients after weeks of this therapy, what was the bottom line?
Well, the researchers quantified the strength gains using a metric called a standardized mean difference, or SMD. Because these 16 trials use different tools to measure strength, an SMD allows statisticians to compare apples to oranges and find the true average effect.
And what was the number?
The overall effect on pure muscle strength, immediately following the intervention period, was an SMD of 0.47 in favor of the electrical stimulation.
0.47. I want to play devil's advocate for a second. In the statistical world, an effect size of 0.47 is technically categorized as a moderate effect, right?
That's correct.
If I'm a listener, maybe a patient or physical therapist, is a mathematically moderate effect really worth all this specialized equipment and time?
If we connect this to the bigger picture, in the isolated vacuum of pure statistics, 0.47 might not sound earth-shattering. But you have to view this through the lens of severe neurological trauma. We are dealing with patient populations that often exhibit zero natural progression in strength. They hit a wall, and they just stay there.
They're stuck.
Exactly. In that environment, uncovering an intervention that delivers a consistent, reliable, moderate positive effect across hundreds of diverse patients is a massive victory. It proves definitively that the treatment reliably works compared to doing nothing or using a placebo.
And it wasn't just working on one specific lucky muscle.
No, and that is what really strengthens the findings. The researchers saw this positive effect across a wide variety of muscle groups. It worked on the wrist and finger extensors in the arm, the muscles you use to let go of an object. It worked on the knee extensors, the quadriceps you need to stand up from a chair. And it worked on the ankle dorsiflexors, those shin muscles we mentioned earlier.
Wow, okay. So the physiology of the artificial workout holds true across the entire body. The intervention reliably thickens the muscle fibers and builds raw torque. The artificial workout works.
Yes, it does.
But that leads to a much bigger question. Getting a thicker bicep while sitting in a clinical chair is great, but a stroke survivor doesn't care about their gym stats. They care about their life. They care about being able to lift a spoon to their mouth or pull open a refrigerator door.
Absolutely.
Building raw strength doesn't always automatically mean you regain complex coordination. Did the researchers look at whether this raw strength actually translated into daily life?
They absolutely did, and this is where the meta-analysis bridges the gap between the laboratory and the real world. Aside from just measuring raw torque, the trials incorporated direct functional measures of performance.
Like what?
Well, they use validated clinical tools like the Action Research Arm test and the box and block test.
Oh, I've seen the box and block test before. It's essentially a wooden box divided by a partition, and it's filled with like 150 little wooden cubes. The patient has 60 seconds to grab as many blocks as they can, one by one, lift them over the partition, and drop them on the other side. It requires strength, grip, release, and coordination all at once.
It is a phenomenal, highly stressful test of real-world motor function. And the Action Research Arm test is similar. It requires patients to grasp, grip, pinch, and perform gross movements like pouring water from a glass.
So what happened when they tested them?
When the researchers analyzed the data from these specific functional tests immediately after the electrical stimulation therapy ended, they found an improvement in activity with an effect size of 0.30.
So a small to moderate immediate improvement in actually using the limb. That's good, but maybe a little underwhelming compared to the raw strength numbers.
On the surface, perhaps. But the researchers didn't stop there. They recognized that recovery is a long-term trajectory. So they looked at the long-term follow-up data. They evaluated the patients weeks or even months after the cyclical EMS sessions had completely stopped.
And what did they find then?
In the long-term follow-up, the patients had maintained their strength gains. The effect size for strength hovered around 0.33, but the activity measurement, that number actually went up. The effect size for daily activity rose to 0.38 in the long term.
Here's where it gets really interesting. They got better at using the arm after the machines were turned off and put away in the closet. How is that biologically possible?
It is arguably the most profoundly encouraging data point in the entire review. What we are seeing is the successful translation of clinical therapy into lived independence.
It makes me think of learning to ride a bicycle. The cyclical EMS is essentially a set of heavy-duty training wheels. For weeks, the machine provides the initial strength, forcing the muscle to contract, building up the raw physical hardware needed to pedal the bike, but you aren't really riding freely yet.
Right.
Then, the therapy ends, the training wheels come off, The patient is suddenly left with an arm or a leg that is significantly stronger than it was a month ago, so they start trying to use it more. They reach for the remote control instead of using their good hand. They try to stand up from the sofa without relying entirely on a cane.
And by incorporating that newly acquired strength into their daily routine, they create a positive feedback loop. The everyday act of reaching, grabbing, and walking becomes their new natural physical therapy.
Wow. They are maintaining and even building upon the strength by simply living. Yeah.
Exactly. The initial electrical intervention fades out, but the functional independence takes over. The researchers concluded that the sustained effect on activity suggests the benefits were successfully incorporated into daily life. That delayed spike proves they reintegrated that limb into their brain's daily map of the world.
That is just incredible. So we have an intervention that builds raw muscle, and we have proof that the muscle eventually translates into real-world movement.
We do.
The next logical hurdle for anyone listening, especially if they are navigating stroke recovery themselves, is wondering, am I a candidate for this? I mean, stroke recovery is notoriously time-sensitive. We always hear about the Golding window of neuroplasticity in the first few months. Does this machine only work if you catch the patient right away?
The researchers were highly aware of that exact concern. To answer it, they sliced the data into specific demographic subgroups. First, they look at the timeline.
Okay.
They divided the patients into subacute and chronic groups. Subacute patients were those who had suffered their stroke less than 6 months prior to the study.
That's the golden window.
Right. And chronic patients were those who were well past the 6-month mark. In fact, some of the trials included patients who were up to 5 years post-stroke.
5 years out is usually when a patient is told they have plateaued and to just accept their new normal.
Sadly, that is often the conventional wisdom. But the data here violently challenges that assumption. The cyclical EMS proved effective for both groups.
Really?
Yeah. The subacute patients, who were still in that early window, saw a robust effect size of 0.55. But the chronic patients, years out from their initial trauma, still saw a statistically significant effect size of 0.33.
Meaning the muscle tissue was still totally viable and ready to respond, even years later. What about the initial strength level? Because you mentioned earlier that some patients can't even lift a dumbbell.
Right. They categorized the baseline weakness using gravity as the ultimate metric. Very weak patients were defined as those who possessed zero anti-gravity strength. They physically could not move their arm or leg through a normal range of motion if they had to lift it against the downward pull of gravity.
And the other group.
Weak patients had some ability to move against gravity, but still possessed significantly less than normal strength.
And did it help both?
It did. The machine didn't discriminate there either. The very weak group, the patients who literally couldn't lift their own limbs off the mattress, saw a strength effect size of 0.40, and the weak group saw an effect of 0.66.
So what does this all mean? If we synthesize this whole section for the listener, it means the door isn't closed just because it's been years since a stroke or just because the muscles are severely weakened. The muscle is still there, waiting for a signal, and this technology can deliver it.
Exactly. And this raises an important question regarding how standard care might need to adapt. The authors of this systematic review drew a very firm conclusion from this data. They specifically recommend that daily cyclical EMS should be implemented for stroke survivors suffering from profound weakness.
That makes sense based on the numbers.
They also point out its immense value for patients who have cognitive impairments resulting from the stroke.
Oh, because progressive resistance training requires the patient to understand complex verbal instructions, right?
Right. You have to maintain focus and execute deliberate movements.
Yeah.
If a patient is struggling with cognitive processing, they just can't participate in traditional gym therapy. But they can sit in a chair while a machine automatically maintains the strength and integrity of their musculature.
It flips the entire paradigm upside down. The traditional model is wait for the brain to heal enough so it can command the muscle and then start building strength. This intervention says, let's command the muscle externally, build the strength now, and keep the hardware in pristine condition for whenever the brain is finally ready to reconnect.
It is a proactive rather than reactive approach to profound neurological weakness.
Okay, let's bring all of this together for the listener. Based on this comprehensive meta-analysis from the Journal of Physiotherapy, cyclical electrical muscle stimulation is a scientifically validated, incredibly vital workout hack for stroke survivors. It uses targeted electrical pulses to bypass a damaged nervous system, artificially forcing paralyzed or severely weakened muscles to contract and adapt.
And the data, which was verified across 16 rigorous trials and hundreds of patients, proves it works. It builds genuine, measurable strength with a 0.47 effect size. It works for patients in the early stages of recovery, and it works for patients years down the line who have been told they've plateaued.
And most importantly, those raw strength gains eventually translate into real-world activity. The training wheels come off, and the patients actually get better at performing complex daily tasks long after the electrical therapy has ended.
It really is a game changer.
Now, we always want to ground these deep dives in reality. As the clinical blog post in our reading stack emphasizes, neurorehabilitation is highly individualized. This meta-analysis gives us the grand statistical average, but every single stroke and every single patient's recovery trajectory is completely unique.
That is so true. Medicine is deeply personal.
Definitely. You should always consult with your neurologist or physical therapist before pursuing a new therapeutic intervention like this. Results vary, and professional guidance is key.
But this data does provide a tremendous foundation of evidence-based hope. It proves that a better quality of life and a return to functional independence is medically possible, even in cases of severe impairment.
Which leaves us with a final thought to chew on. We started this conversation by imagining the utter frustration of a broken connection, a brain screaming at an arm to move, and the arm doing nothing. But when we look at the delayed spike in activity scores where patients improve their coordination weeks after the machine was turned off, it forces us to reconsider how healing actually happens.
It really does.
If simply forcing a muscle to contract with external electricity can eventually lead to a patient voluntarily reaching out and grabbing their morning coffee, how much of stroke rehabilitation is actually about fixing the brain? And how much is simply about reminding the physical body what it feels like to move, keeping the machinery well-oiled until the brain remembers how to drive?
That is a fascinating thing to ponder.
Thank you so much for joining us on this deep dive. We hope this exploration leaves you not only better informed, but deeply appreciative of the absolute resilience and adaptability of the human body. Keep asking questions, keep pushing boundaries, and we'll catch you on the next deep dive.